No, maybe. All right. Well, if you don't, I wouldn't worry about it too bad. So we're gonna do this check on learning thing at the end that I promised you. Remember that?
Cool.
I can mix it if you don't. Up to you. Here we go. Pay a little bit of attention to this. Very important to have an idea because this allows us a little bit more in our pathophys and understanding. So I want you to pay attention to. Obviously, we have ascending colon, transverse colon, descending colon. Everybody's tracking on that, right? Pretty simple. But let's look real quick. We want to know where the cecum is. It's right next to the appendix. There's certain things that happen there. And we also have the sigmoid colon. What happens down in the sigmoid? We're talking about pathophys and pathology. What type of things happen in the sigmoid? Diverticulitis, cool. What also happens there? We'll talk about it at the very end of this. If anybody actually pre-read the slides, you'll be real surprised. Everybody starts with V. Lobulus happens there. Okay. Just to give you an idea, very important to pay attention to those types of things. You obviously have your splenic flexure because it's near the spleen. You have your hepatic flexure because it's near the liver. So make sure you use the big boy words in phase 2. Okay. Or big girl words, sorry. So here are your different types of studies. So air contrast, barium enema. I don't see this a lot, but you need to be aware of it. So double contrast. And we look at our flex sig, our colonoscopy, and then our virtual colonoscopy. A little bit more on that. Sorry, that's the next slide. Jumped onto that. So virtual colonoscopy, I think that's very interesting. So when you go virtual here, I absolutely hate it. But here's your air barium enema. So they basically insert barium into there. That's done under fluoroscopy to make sure they paint all the colon to take a look at what they need to. This is a little bit more old school, a little bit more archaic, if you will. Do this more in third world countries, not so much in the United States. But after they do that, then they inflate everything so it opens it up so we can get better images of that. How does that look when they take X-ray? Right there. Pretty interesting. So see, everybody's colon's going to be a little bit different. So that kind of transverse colon's really dipping down a little bit, but you know, like everybody has a different face, everybody has a different fingerprint. The colon's all a little bit of abnormalities. So that's what that's going to look like. Again, probably not going to see very much of these, but if you do, your attending wants to ask you questions, at least you'll have an idea what that looks like. Here's our flex sig. Again, we're looking at what we consider about a third of the colon. That's going to be the descending colon. So this is done by the rectum. So again, this has to be a planned procedure, like a colonoscopy. So if you go in there like, oh, I'm just willy-nilly going to do this without any prep, you're not going to see much. It's going to be full of fecal material. It'll be full of fecal material, FOS, right? So we only see that little bit. So they're probably looking, maybe just a quick look for prep for diverticulitis. Not going to see anything except in the descending colon versus a colonoscopy right there. The whole gamut. So like the video said, 45 years, or they can move that timeline up. So I do want to take an opportunity to discuss, everybody familiar with the commercials, Cologuard? When people go in, they basically send it in the mail, you poop in some container, send it back to them, they're going to screen it, basically looking for blood that's in there. Instead of cancer screening. A lot of people get upset about that because they get it done, they think that's an alternative for your colonoscopy. It's not. And if you're military medicine, it's not a big deal, you don't have to worry about paying for that type of thing. But a lot of people in the civilian world get upset, they go 45, I got my Cologuard, it came back negative. Well, guess what? You still need a colonoscopy. I would say Cologuard potentially higher, more concern for risk of cancer. Maybe you get that done earlier, and that just necessitates that for a colonoscopy. Cologuard doesn't tell us how bad the cancer is, doesn't tell us what polyps are doing or anything. So be cautious with that Cologuard. It's obviously in the middle of jeopardy, so it must be doing pretty well as far as pay for commercial. Here's the interesting one. People that cannot or fail the colonoscopy. So they can get a virtual colonoscopy. We also look at these as cancer, colorectal cancer screening in patients that cannot get a colonoscopy for whatever reason, cannot get a colonoscopy. So that's going to evaluate the colon. Usually if they find an obstructing lesion, they can come and do a virtual colonoscopy, see if there's any metastasis or whatnot. So here is how that views. So person obviously going into a CT scanner. We're going to look at that whole colon. They can break that down into different parts. Look at that right here. Pretty interesting. I think it's interesting to call it a virtual colonoscopy. It's like you just sit at home on your computer and do it? No. So it's an actual procedure that gets done in a radiology suite. Other studies that we can do, this is going to be looking more for things that are very proximal to the anus rectum. So rigid sigmoid scope, endoscope. So interrectal pathology, what are we looking for there? Talking about things like internal hemorrhoids, we need to look for fistulas. We're looking to see how extensive maybe a fissure is from looking from the inside versus just looking from the outside. So that just gives you an idea of our different radiology modalities that we can do with this. But let's get into diseases of the colon. Here's the things we're going to talk about. So C. diff. So anybody who's worked in a hospital knows what that smells like. Knows what that smells like. Very distinct smell. So we're getting diverticular disease, which is number one for what type of GI bleed? Lower GI bleed. Okay. Upper GI bleed, peptic ulcer disease. Lower GI bleed, diverticulitis. Rectal bleeding, very different from lower GI bleed. Okay. That's going to be hemorrhoids. And then we talk about obstructive processes. So do not get this confused. C. diff is not the same as antibiotic-associated diarrhea. So I tell all my patients that I put on Augmentin, hey, you're probably going to get diarrhea. That's like 90% of the population is going to get that. But it's not the same thing as this. So again, bacteria that grows naturally in there is going to get killed by antibiotics. So usually very mild, usually self-limiting, gets resolved, but we get concerned about this. So CDI, going to be the acronym for that, CDI, major cause of diarrhea. This happens in people that are typically hospitalized. So this is like a antibiotic-related thing, but it's also a hospital-related thing. Look at that, up to 21% of patients, so 1 in 5 almost. 1 in 5, actually a little bit more than 1 in 5, okay? So this can go anything from just mild diarrhea, not too concerning. Maybe you're thinking this is just antibiotic associated, but it can go to pulmonary disease and toxic medical colon, which we will talk about. Toxic medical colon is a very, very serious disease process. So how does this work? So these form spores, they are opportunistic, and they produce toxins, specifically toxins A and B is what we're concerned about. This causes damage to the mucosal layer inside of the colon, So this can be transmitted from person to person, which is why these people typically need to be put on some sort of isolation. A lot of times they will put them in an isolation room as a negative pressure. We do not want that spread. We're not going to put them in a room with someone else. So yes, that can happen in fecal oral. Everybody clear on what that means? Yeah. Something dogs do on the regular. But we want to be very careful. This is why it's not just important to wash your hands. Hospitals have nasty stuff that grows. That's called nosocomial. Nosocomial. Those things grow in ventilators. They grow on surfaces. Look at that. Up to 5 months, C. diff can sit on a surface if it's not cleaned properly. Not cleaned properly. So, and we live in a first world country, so this shouldn't be as much of an issue, but it is. So this can go on toilet seats, doorknobs, bed linens, hands. So make sure you wash your hands, not just because you're worried about the hand washing Nazis, but you really should do this. You don't want to take C. diff home with you. So here's what the antibiotics do. They disrupt in certain antibiotics that we'll get into. They allow that C. diff to flourish. So C. diff is naturally there, but our natural bacteria helps keep that in what's called homeostasis. Okay, that's good when things are in balance. Good when things are in balance. With that C. diff to start flourishing. Here's your most causative agents. Just be aware of that. However, any antibiotic, but we found that there are some usual suspects right there, AMP, clindamycin. You got a third gen cephalosporins, chlorphenols. For you visual folks, for you visual learners, right there. So they're not going to say on your pants what is occasionally associated. I would definitely know those 5 things. I'm not saying for the test, but I'm saying for the pants in the future. You can ask a lot of questions like that. Which of these antibiotics? So if you want to, you can click this link if you'd like to go to the American College of Gastroenterology Clinical Practice Guidelines to tell you, hey, here's how we treat this. Here's how we treat this. Okay. So here's what we look for: mild to moderate diarrhea, usually greater than 3 days. 3 days or greater. So it's going to be described as watery. It can be greenish. I told you that foul smelling. Most nurses, they'll tell you that say, yeah, I can smell C. diff from a mile away. So it's been described as resembling manure, rotten eggs, anything from similar to decaying fruit or vomits, and sometimes musky and pungent, similar to body odor. So we see lower abdominal cramping, tenderness to palpation on exam, so just all over, and we see a mild leukocytosis. So what's normal for a white count? What's normal for a white count? Below what? Below 12,000. Okay, below 12,000. So we're looking at 15 here. So it's not going to be something like barely over the edge. We're typically going to see greater than 15. And then we're going to see a bump in this serum creatinine. And I'll talk about that a little bit more in this next slide. Like, why does the creatinine go up? I'll talk about that. You get severe disease, again, that diarrhea. We're going to see lower quadrant or diffuse abdominal pain, distension, but now we're starting to see that they are febrile. This is concerning. Now they're febrile. So that leukocytosis again, usually greater than 15,000. That serum creatinine. Why do you think that we have the creatinine going up when we're talking about a GI problem? Now we're affecting the kidneys? Any ideas? When you're peeing out of your butt, you're probably getting dehydrated. Okay? Now, dehydration is going to cause an acute kidney injury due to severe dehydration. These people are literally sitting on the toilet. And then we get that hypoalbuminuria. So that's going to be a decrease in that, and that has to do with a combination of inflammation that's happening inside the colon, as well as malnutrition. Why? Because it's going through the GI tract so quickly that it's not able to take all the nutrition from that. And then we have elevated serum lactate. What have I told you? Have I told you what lactate is indicative of? That's hypoperfusion, that the body's not getting the oxygen that it needs to where it needs to. So that's typically has to do because these people start getting septic, they get hypoperfusion, so they go hypovolemic, they go hypotense, and then potentially progressing to sepsis, and then we're getting into a different world. So talk about that: shock, severe hypotension. So that can be with or without vasopressor. If it's getting significant enough, we are reaching for vasopressors. Everybody tracking what vasopressors do? Help constrict all the blood vessels, make the heart pump quicker, so it can counteract that hypotension. So we also get ileus. That can happen after a while, after they've had enough diarrhea. That colon's going to dilate. When that colon starts to dilate, we don't start moving things along, we get an ileus. And then we can progress to what's called megacolon. I want you to pay attention to that. It's greater than 6 centimeters in diameter in the colon, or 12 centimeters in the cecum. Where's the cecum? Right lower quadrant, left lower quadrant? Right, good. Right next to the, thank you, good job. And then we can potentially develop this pseudomembranous colitis. This is we're transitioning basically from a CDI to a toxic megacolon. So severe inflammation. What they can see if they do a colonoscopy, they're looking in. Obviously, we have to do that. Potentially, this could be seen with a flex sig, but most of the time colonoscopy. So yellow, off-white plaques scattered all over the chronic mucosa. Sometimes it can be mimic inflammatory bowel disease with the skip lesions, but this is very specific for that pseudomembranous colitis. What I want you to pay attention here is we basically identified that with new onset unexplained diarrhea within 24 hours. So 3 unformed stools. And that's pretty like a wide thing. That doesn't mean I need you testing everybody for C. diff, like we had diarrhea 3 times. We need to check this. We have a little bit more idea with that. So what are we going to typically see? We'll talk about that here in a minute, but it's obviously usually some antibiotic use that occurs to that. So don't be like sitting everybody's stool sample down. But here's what we do with that. So we have that GDH right there. Glutamate dehydrogenase. That is what we're going to do. How is that all done? This is all done by stool sample. All done by stool sample. And I will tell you that if somebody cannot produce a stool sample for you that quickly, probably don't have C. diff. You should be coming out of that end and not be a problem. Not be a problem providing a stool sample. Yeah, it is kind of weird. You give them a cup and put that in. Hopefully you give them a bag to walking around with that weird thing. So positive and get that EAI, and then if indeterminate, we can do another test, and they're going to take that stool sample, they're going to slot it and test it again in a lab. So if we think this is severe enough, meaning they have fever on top of that, we did a CT scan, we're seeing this is pulmonary, we've got the test done and everything, so we may need to evaluate for toxic megacolon, because that can lead to perforation, where it ruptures. We don't want colon, because then fecal material goes where fecal material is not meant to go, and that causes bad things. And then potential for surgical indication of that, they can go and potentially remove part of the colon. So CT, the abdomen pelvis, yes, that's going to be with IV and oral contrast. IV and oral contrast. So not something you're going to be doing in your TMC, but in cinema or radiology, they can handle all that stuff. Just be prepared, you may have to send that person with some Zofran. It's a lot of contrast they have to drink to make this effective. And then, of course, plain films, if CT is not available, sure, in a pinch if that's all you have, or if CT is contraindicated, you don't want to do that typically in kiddos or pregnant patients, there's potential for that. So how does that look on CT scan? It's pretty nasty, right? Pretty nasty. So you can see that right there. That's probably more in the transverse colon, blue one. You can see that. On the other slide, that's going to be more in the descending colon, What can happen with this? Here's our complications. Here's our complications. Obviously, people are going to get hypovolemic, hypotense. Due to that drop in albumin, can also cause some hypercoagulability, which puts them at risk for what types of things if they're hypercoagulable. PEs, PETs, what we call thromboembolisms. We'll worry about that stuff. It can progress bad enough. Typically, these people that are going to have respiratory failure probably have some other comorbidities that's going on with that. But we see some metabolic acidosis, progressing to toxic metabolic, and that's not good. And then bowel perforation, very concerning. Surgical requirements. If it's that bad, we admit these folks. An infection control procedure is very, very important. You're not going to put somebody in the room, you're going to isolate them, by themselves. And you're probably going to have everybody's going to go in gowned up in there. And I would put gloves on, and I would probably breathe as slowly as I possibly could, just saying, we do not want to get that. We need to stop that offending agent. It's typically some type of antibiotic that we talked about. But you're worried because they've been having so much significant diarrhea, we need to make sure we're looking at those electrolytes. What's going to typically drop that we're going to see? Which electrolytes are going to potentially go down that we're concerned about? Potassium is probably number one. I'd say potassium is probably number one. How much diarrhea, the body's not absorbing it, and it's just dumping that potassium. Not good. So, what do we reach for? It sounds crazy, right? We're going to treat something that was caused by antibiotics with antibiotics. So, preferred regimen, we like to do this PO. So, and then vancomycin, a lot of these people, if it's mild disease only, we're looking at metronidazole. Just be aware that's 3 times a day versus the other one is 2 times and 4 times a day. So you got to be concerned if you're going to be treating this PO with patient compliance. You need to let them know I need you to take all your antibiotics because this has a high recurrence rate. And then we get concerned, is it with or without ileus? With or without ileus. All that means is if they're without ileus, we can continue to go orally and intravenously. We can also do that via nasogastric tube because we want these people to have some bowel rests. But if they have ileus, we're going to be reaching for an enema. Reaching for an enema. Reaching for an enema. If they're high risk, they've had a lot of recurrence. These people are immunocompromised, meaning that can be immunosuppression, for whatever reason. So, or inflammatory bowel disease in people that are on dialysis. We need to be very careful with these folks on dialysis. So we need to reach for this Zimplava, and then probably talking to a surgeon. They need to be closely involved, whether that's you're in the ER, you're in internal medicine, you just consult surgery and say, hey, can you come over and take a look at this person? Come over and take a look at this. So 20% risk, 1 in 5 risk of recurrence within 8 weeks. So failure to eradicate typically due to medication compliance. So, and then your risk is going to double each time. So these people just kind of get susceptible to this. So after they have a third episode, it's probably just going to continue to happen. This would really stink. So there's your risk factors. Number 1 is going to be that recent antibiotic use. But people that stay in the hospital for a long time, comorbid illnesses. So that's anything diabetes, coronary artery disease, CHF. So elderly patients and then are immunocompromised. How does this break down real quick? First, recurrence, aka their second episode. So that's how long we're looking at using those medications. We are not reaching for metronidazole. That's for mild disease, no recurrence. Obviously, we need to use a big gun, vancomycin. We take the pants, and it's like we've tried all these antibiotics. What do we need to go for? Zosyn and Vanc are probably your 2 biggest guns. So that's why vancomycin's on there. And then this is crazy. Greater than 4 episodes, we consider fecal microbiota transplantation. That's crazy. But it's 90% effective. Right there. Via retention enema, sigmoidoscopy, endoscopy, or colonoscopy. So oral capsules, you're basically taking healthy poop, donating it to somebody who has sick poop. That's basically how it's working. I think it's weird that they have oral capsules that can do that. Yuck. Anyways, we got a good visual. Toxic manifold. This is when that colitis gets really bad. So it's gone toxic at this point, which is a easy term. It's not just a song by Britney Spears. It's been an easy week. And that wasn't delivery. I did. So larger than 6 centimeters, yes.
Quick question. So the barium, we were taught generally to stay away from barium if there's risk for a GI cramp. So that's a risk for both.
Absolutely. If you're worried about a perforation, yeah, absolutely. If you have any questions, I mean, it's going to be different in everybody's MTF where they go train in phase 2. If you have any questions or concerns about that, yeah, you want to stay away from barium with that. If you're really worried about a perf right away, let's probably get a chest x-ray upright, see if there's any free air, just to be sure. Most people that are going to be in pretty bad shape, pretty severe pain if they have their perforation. So, again, this is non-obstructive. We worry about this getting systemic toxicity, so sepsis. So just be aware that this can also not just be caused by CDI, this can also be related to inflammatory bowel disease. Specifically, the precursor is ulcerative colitis. So be concerned about your people with ulcerative colitis can progress to toxic colon. Now, how do we work this up? A little bit of throw in the kitchen sink. So that albumin is going to be included in that CMP, but we want to CBC to see how bad leukocytosis is, or is there any anemia. ESR, CRP are your what kind of markers? Inflammatory. Okay. Just be aware that most ESRs in most military facilities are going to be a send out. going to be sent out. Now you're working the tube, so you don't have to worry about that. But you're working in the hospital, you're not going to get that back. You get a CRP back within an hour. And then obviously we're sending in their stool studies. Sending in their stool studies, so we're really concerned about that. And then abdominal pelvic CT, oral and intravenous contrast. Oral and intravenous. So, what's our criteria for diagnosing that? So we need to have evidence on that from CT, evidence by CT, and then 3 of the following. So we're going to see they are febrile. We're going to see that they are tachycardic, typically above 120, not borderline. So tachycardia is what, over how many beats per minute? Good. And then a neutrophilic leukocytosis, yeah, that's great. It's above 10.5, but we're going to see the left shift. We're going to see a predominance of neutrophils or bands, however that works, and then anemia. And then at least one of the following. So altered mental status, electrolyte disturbances, hypotense. How do we determine somebody's dehydrated?
Skin temperature?
You can do skin sugar, sure. We can do tilts. You can also, typically, if we have a baseline creatinine, we would typically see a bump in that. So usually acute kidney injury is associated with that. Usually they resolve real quick with some IV antibiotics. Just some images for you of how that can look. Looks pretty nasty. Have a lot of distension that's going on there. It's free air, typically. Why bacteria produces. And then how do we treat that? So we need to make them MPO. So if somebody comes in, that's the first thing they come into the ER or whatever. You need to put an order in for MPO. Because even if you get them feeling better, it's not going to help them if they start eating. They need that bowel rest. We need to look closely at those fluids. Creatinine, do an idea, maybe they're hypotense, but we want to fix all those electrolytes. Fix all those electrolyte disturbances are occurring. And then we treat that toxemia, obviously antibiotics, because it's typically caused by C. diff. But if it is inflammatory bowel disease, which is caused by Crohn's or ulcerative colitis, okay, we need to give some glucocorticoids to help calm that down. And then get our surgical folks involved. I'll let everybody just take this slide in because that's everything I talked to, but some visual folks. There's some very interesting stuff out there. I'll show this. What is your next lecture? Ortho. I just want to start earlier with that. Heads up. Receive track on it. All right. Questions on CDI, toxic colon, that transitions from the pseudogranulin colitis? Any questions? You guys will crush the check on learning, I'm sure, when we finish up here. Peter Kelly, I don't know where he finds these cool pictures. I mean, that's pretty good, spot on, like diverticular disease. That's more of a diverticulosis, but some ruptures. They're pretty bad. Gives you an idea of what? Yeah, it's a sac-like protrusion in the chronic wall. This happens. This is what I call a first world disease. You do not see a lot of diverticulitis, diverticulosis in third world countries. Why? We smoke, we take medications, lives a little bit more sedentary. Fiber is probably the main thing that we're talking about here. And then diverticulosis versus diverticulitis. Losis just means you have those sac-like protrusions. Diverticulitis means they get inflamed, they get angry, they bleed, they can get abscesses, they can rupture, that's bad. That's what that looks like. Not just the Hofstra, these actually start forming these sac-like protrusions. Sac-like protrusions. And you can see that's evidence of that right there. This is a very common incidental finding in older folks. When I say older, it can be different for everybody else over the age of 50. Very common to do get CT scans on these folks and have this as an incidental finding. Incidental finding. Usually asymptomatic. Why? Right there, asymptomatic. It can vary based on people. Where do we see those? Where's the sigmoid? Right lower, left lower. Talking about diverticulitis, left lower, here we go. Good. So, right there, asymptomatic, but descending colon in the sigmoid. The past the descending colon is the sigmoid as we get closer to the rectum. So low fiber, and people just they'd rather drink Coke all day long or whatever, coffee, tea. So insufficient water intake, and low fiber contributes to this quite a bit. So, already said this, incidentally, usually asymptomatic. Incidental finding is fine. Recommend you increase. How do we fix that? Increase your fibers, increase your water. A lot of old school stuff, they say, well, it's because you eat too many seeds, you eat too much different types of tree nuts, or too much popcorn. That's kind of an old wives' tale. I don't really tell people that anymore. But you tell them to increase their dietary fiber and water intake. So, like I said, number one cause, lower GI bleed. That could be a PANCE question. That could most definitely be a PANCE question. So painless is typically painless as it starts out initially. So bright red blood, why? Because it's right there, the sigmoid, or right there at the descending colon. So when people can complain of squirting blood in the toilet, most people don't usually look back there and check. Most of the time it's found on toilet paper when they're wiping. So usually no other symptoms. If they are having active bleeding, we need to make sure. So we are going to do a digital rectal. We're going to take a good look back there. Why we need to quantify how much bleeding we're talking about. Patients can over-exaggerate, but they can also under-exaggerate those types of things. Make sure you have a chaperone when you're doing this. I don't care, male, female. You're male, you're female, does not matter. Chaperone all the time. That needs an endoscopy. They need to go in there and take a look at it. If they're concerned about endoscopy causing worse perforation, always concerned, especially when they're going to inflate. So that's how they look at everything with a colonoscopy. Plus, they're going to do that. Probably going to have some time to prep that if they can. But without active bleeding, we just kind of refer them to GI. So uncomplicated. So we usually don't worry too much about that, but they can have microperforations. That's from that inflammation right there inside of those sacs. It can be very concerning. So sometimes can cause some systemic inflammatory response for sure. It's complicated. Those people probably need to come in and worry about them perfing, worry about them continued bleeding, getting anemic. What can significant GI bleeding result in? Do we get concerned about that? I mean, if they're hypotense, can that do anything other damage to the body? Are they familiar with the type 2 NSTEMI? That's a supply and demand. I've had numerous GI bleeders come in and their troponins elevated. Does that mean they need a stent? No. I mean, we need to give them blood product and get this fixed. So the heart can get overwhelmed with that supply and demand and it can cause extra stress. So again, worried about obstruction with these fistulas. Phlegmon is just a precursor to an abscess. There's something called the Hinchney classification that should come back on that CT report. You're worried about diverticulitis, I probably CT everybody, even though they say you don't necessarily need to. I think you do, because I'm worried about if there are any complications. There's an abscess in there based on the size of the abscess. That needs to be taken care of by surgery. Where do we have this? So this is right lower quadrant, worried about appendicitis. Left lower quadrant, worried more about diverticulitis. Not to be confused with a Meckel's diverticulum. Where is that going to be? Left lower quadrant, right lower quadrant? Right lower quadrant. Okay, near the ilium, which is also close to the cecum, which is also close to the appendix. All right, fever, nausea, vomiting. Worry about that. Most of these people are going to have left lower quadrant tenderness palpation. Left lower quadrant. Left lower quadrant. So about 1 in 5 of those will have a left lower quadrant mass. We worry about fever. So any peritoneal signs concerning the complication. What are peritoneal signs? I say anything in the realm of guarding or rigidity. The guarding being voluntary, rigidity not voluntary. Leukocytosis on the CBC plus or minus the stool. So they may be bleeding microperforations, they may not. Don't take that. Be like, oh, it's not diverticulitis, I didn't see any bleeding. Whack, came back negative. Just be worried about that. Okay. CT abdomen with contrast. It's going to be with contrast. So with contrast. Why do we get a BNP on most of these folks? Not because I'm worried about it, I'm gonna make sure there's no kidney injury, sure, but that BNP needs to be good so that I can give it in contrast. If their GFR is too low, the creatinine is too high, radiology is gonna be like, nope, not doing it. So, or they have contrast allergy, maybe be concerned about that too. No endoscopy, flex-saver or C-scope. Worried about that perforating, making things worse. Again, we may be evaluating for rectal disease or rectal bleeding, or we may be evaluating for lower GI bleed, but we want to make sure we get that CT scan to make sure that it's not a diverticulitis, because we worry about perforating. Mild disease, conservative treatment, that can be outpatient management. So we tell them to go on liquid diet. We tell them to come back to the ER, we're going to reassess and be working 2 to 3 days. So, and then once that resolves, C-scope 6 to 8 weeks after resolution. These people can not improve, they fail outpatient treatment, then they're probably going to come back and be inpatient. So if they fail to improve in 2 to 3 days, so they can't tolerate their PO fluids, whether that's having severe nausea or vomiting, and we need to bring them in. So here's your criteria for inpatient treatment. So complicated diverticulitis on CT, it'll say that. I'm going to give you a HG score on that. So obviously if sepsis, we don't send those people home. I don't like sending people home with abnormal vitals, period. Abnormal vitals, period. So severe abdominal pain that we can't get under control. And then we have people that are really old, high fevers, immunocompromised, comorbidities. We can't get somebody PO tolerant. We can't send them home if they can't keep anything down. And then again, if they fail that outpatient management. Severe disease, you click, you're in the ER, you're going to click a button that says NPO. Nothing's going to get somebody more fired up when they come down to see your patient and they're like chowing down on a burger. You want to get a surgeon really upset, you want to get any inpatient person really upset, have that patient come down and not be NPO when they're delivering. It's really big for surgeons because then they can't take the evaporating room. So make sure giving them fluids, their electrolytes are off, and then good pain management. Yes, side effect of that is going to slow everything down. So be it. It's just a side effect of that. Should put them on some type of stool softener. And then as long as can be discharged as long as they can complete a oral antibiotic course. Here's your complications. Complications, perf, obviously, the abscess formation. Sometimes they can go in and drain those. Interventional radiology, but a lot of times they can be surgically resolved. We were about fistulas and then obstructions as well. So get that CT scan. I say probably get a CT scan. Everybody, especially when you're in phase 2, cast that wide net. You're going to be working people up more. You're going to be X-raying, CTing people more, but that's fine. Figure out your line of the stand, feel your safe place. Questions on diverticulitis disease? Again, number 1, lower GI bleed. Number 1. Now we have this pseudo-obstruction, Overby syndrome. So obstruction without a mechanical lesion. So for whatever reason, there are causes for this, we'll get into that. So basically it's paralytic ileus. So where's that? Cecum and proximal colon. So cecum and ascending colon. So we can see some dilatation on imaging. So how does that happen? This is neurogenic failure. So peristalsis. Peristalsis stops the natural moving of the colon to move fecal material along. At that point, not food anymore, it's back to the colon, working its way towards the rectum. So usually hospitalized patients, a lot of times they don't want to discharge these folks until they can have a bowel movement, and discharge people until they can urinate. Post-surgical, usually relates to trauma. A lot of these people are intubated, they're in ICUs, things like respiratory failure, MIs, congestive heart failure, all run the risk of this. This is typically an inpatient issue. How does that present? Distension, and mild abdominal pain, nausea, vomiting, obstipation. What does that mean? There's constipation, there's obstipation. Obstipation, I'm not doing anything. I didn't try. Nothing's moving at all. No bowel movement whatsoever. So CT, we want to make sure that we're not dealing with some type of bowel obstruction. And if we talk about bowel obstructions, what is typically the most defending agent for that? What risk factor? Instrumentation in the abdomen. So any type of surgeries that they've had, people that have had their gallbladder out, people that have had appendix out, people that have had colectomies, any type of surgical to the abdomen. And yes, you'll ask people, do you have surgery before? And they'll say no. And then you're evaluating their abdomen, you look kind of like, what's that scar from? Oh, I had my appendix out. And people are just poor historians. Some people just shouldn't procreate and whatever. So you need to admit these people, put in an NG tube. You get a chance to do that. Don't let the nurse take over that every single time. Pretty neat thing to put in there. We need to decompress, treat the underlying illness. Again, most of these people are inpatients. We do want to prevent any medication that can slow down the GI tract and then potentially tough surgery. Now we're going to talk about what I said happens in the sigmoid. We talked about diverticulitis, but we also have this. This is basically a torsion that happens. Torsion can happen to ovaries, torsion can happen to testicles, torsion can happen in the sigmoid colon, right there, leads to obstruction. Sigmoid colon, most common, but it can occur anywhere, Clinical presentation, progressive abdominal pain. So severe pain, I would say in the realm of pain out of proportion on exam with these folks. Why? It's cutting blood flow off and causing significant ischemia. All these other symptoms that you can see that occur with that. So distended abdomen with tympany. So if you're actually to percuss, and palpation, and then again lab test don't tell us anything, we need to get that CT scan. Very low threshold in the emergency department. I don't get too concerned about radiation unless it's to kiddos or pregnant women, but have a low threshold to do this for your patients. Questiones? You're like, hurry up, let's go. We could push on, but how? Anything not clear? Other than how bad my jokes were. All right, here we go. So here's what we call a second order question. If you can't figure out the diagnosis from the question, you're probably not going to be able to pick the right answer. Juniors now get to pick up their game. So, what is this disease process? Yeah, where's the question? God. I'm being nice to you guys. Not being nice back. All right. What are we going to use to diagnose this? Did I ever talk about CT angiography so far? No. I did talk about colonoscopies. I did talk about double contrast enemas. KUBs are worthless unless you're looking for constipation. But what are you going to use to diagnose this? It's going to be a CT, abdomen, pelvis, with or without contrast? With contrast. Yeah, I got the question in there. It's a pretty easy one, right? But remember, there was 4 other things that could be, right? That all pretty much relate to potentially being hospitalized or being old or being immunocompromised. But this one, obviously, pretty simple, recent antibiotic use. Well, you got your choice of B, C, and D because I didn't talk about Levo or Clenda. That's just good test taking skills, eliminating some stuff and break it down. I did talk about bank, but I only talked about bank and not PO, so that's out. So it's going to be metronidazole, only for bowel disease. And do we use it in a second recurrence? No. Oh, good. Second recurrence, right? It should just be recurrence. It's like the first annual. Inaugural? Okay, gotcha. And there's some lines are blowing out there, I got you. Got the question there that time? All right. 3 out of 4 isn't bad. Great batting average. So anything over 6 centimeters, concerning for. We will talk about spontaneous bacterial peritonitis. That's a sad thing. We did talk about pseudomembranous colitis. But we're 9 centimeters, we're past that pseudomembranous colitis, and we are in toxic medical lane. We will talk about acute bronchitis at some point. Alrighty, I will remain up here for a few minutes if your light bulb didn't go off for anybody. Sometimes you do got a pull.